Okay, thank you. Right. So this case, I don't have an awful lot of clinical info because it was the result of a telephonic consultant. So I'll give you what I've got and see how it went. But right. So our case was a 38-year-old lady that was from PE, and she was basically managed entirely in the private healthcare system. And so she has a past medical history that I believe was that she had recurrent childhood infections while a student. She experienced numerous episodes of meningitis, so-called encephalitis, although she seemed to have emerged from them pretty much unscathed, that she was not, didn't have any sort of long-term neurological problems. And there have been many visits to medical practitioners for various illnesses. And in fact, to corroborate that, there are multiple empath reports that I got sent. I've just given you a selection of, selection of the type of clinical results that I thought might have some bearing on the case. So you can see since 2013, they had her on record. She had always seemingly had a lowish white cell count, absolute, lymphocytes were generally low on numerous occasions. She also had lower immunoglobulins, particularly the IgG, or sort of when they weren't low, they were really at the low range of norm. And in 2021, they had done a fair battery of tests. You can see the abnormal results in the red. And one of the things, apart from showing that she had these their IgG was kind of just in the normal range. But they found her they tested her immunity to antigens, and you can see that she had no reactivity to them. However, when boosting her with giving her a dose of vaccine, she had a reasonable response to that, so it wasn't necessarily terribly that. Okay, so the history as far as the consult concerns started November 2024, where she was admitted to a private hospital with headaches, fever, nausea, vomiting, and I didn't have cell counts, but they did a whole lot of PCRs, as you can see, basically similar set of multiplex PCRs that might be often given here, and she was negative for all bacterial targets. However, of note, she was positive for HHV6, and because she was positive that it be on the multiplex assay, they did a viral load in the blood and in the CSF, and you can see that she had a reasonable viral load in CSF, slightly higher in blood. Of note, she was also enterovirus positive and in her CSF. And yeah, so those were basically her results. And they decided that she probably had HHV6 encephalitis, and they treated her with 3 weeks of IV and cyclone. And they were gratified to find that she actually responded a lot better, and went up in December the following a few weeks later. So then, okay, so in February 2025, she represented at the same hospital with similar symptoms, basically what sounded like an aseptic meningitis picture, and they repeated all the PCRs on SCS, all the PCRs. What you can see in this, I've just included the November and the February results, so that you can get a reasonable comparison. So the HHV6 is still positive in CSF and in blood. The enterovirus is negative on this particular CSF, and you can see the rest of the findings, no issues, yeah, nothing otherwise to remark. Okay, oops, I'm doing that, yeah. So now I'm giving it all away. Never mind. Okay, so at this point they put it back on the IV guide slightly better, and they phoned Stan to get an immunology consult, and he phoned me to get a virology consult. Stan Rees, yes. So
when was this case?
last year.
I didn't know it was still practicing.
Well, he was there. Yeah, so I think he likes to get out.
Yeah, okay.
It's because he often puts and so so I just thought maybe the audience could give some sort of opinion of what they think might be going on here.
It sounds like he's got a primary immunodeficiency from different childhood, but ultimately multiple infections, multiple direct infections. So it's probably underlying six.
Yeah, I mean that HHV6 probably is a red herring, right? Because it can't explain her childhood history. So we know she probably is vulnerable because she's got unexplained lymphopenia for what 12, 15 or so years. And it's not surprising if she's got this, but I think you still have to get to the bottom of why she's got lymphopenia.
I mean, somebody was telling me last week, I think, that a viral load of 3.
Virus.
An HIV seroconversion. Has she had been HIV tested?
I'm not entirely sure. I don't think that information was available on the onset she said that was sent.
I think we've got to go with it.
So okay,
I mean, really, I suppose.
I mean, which of those results do you find irritating that you don't entirely entirely explain about what's going on?
Well, if it is a meningitis, it's a viral loads, lower blood.
Yeah, well, that's yeah. You're starting to get closer to the root of the problem.
Yeah, so it's not actually. Is it actually infection of the brain, or is it just coming from blood? Has she got some sort
What you got?
of abnormal pathways into her brain? Blood, no, she's got HTLV blood.
She hasn't got HTLV. Maybe I should ask her.
Yes.
Didn't tell them what this is.
Ask the person with the viral load.
What did I do with principles? Oh, we did discuss. No, I know. Or put it this way, what did I say you must do? Do them together, take blood, and do as it is. Okay, well, what I did was I first asked him, was that HHV6 viral load that was done on blood, was it done on whole blood or was it done on plasma?
Is it high enough for that?
Well, the thing was, I asked him if it wasn't done on plasma.
Ah.
He didn't know I had to get hold of two reports.
So that value is going to change basically depending on how many cells it has. So what is happening? What does HHV6 do?
Well, so let's try to remind us. I was taking what we needed to do.
I mean, what you mean, what it do, you know, as opposed to reactivate.
You have germline insertion of HHV6.
Yeah.
And in those cases, you get super high viral loads. But in here, in CSF, it might not be, because it's going to match the cell count. So essentially, it's coming from the cells, not the virus. But there, like I said, if that was done on plasma, which would also have a low cell count, that would also explain done on whole blood, value would be millions, be extremely high.
So that's what I said. I was starting to say that I thought that this patient had inherited chromosomal integration of HHV6, and that that we need to test out the whole blood and some other sample that definitely doesn't have sites like hair or nails and things like that. And they tested all three for us, and you can see the viral load in the whole blood is now log 6, which is probably pretty equivalent to the number of sites that you have. And the hair and nails also. So let's see. Okay, so that's what. So the key thing here is that some individuals have virus integrated into their genome. We'll talk about more how that happens. And the DNA is present in every cell. So I'm going to just give you a little brief reminder of HHV6. So it is a beta herpesvirus. It's more famous as it is human cytomegalovirus. So it's in that same family of herpesviruses, but within the, I'm not sure my classification isn't that great, but it's a roseola virus, and there are 3 different roseola viruses. There's HHV6A and B and HHV7 are all genetically very closely related, although they are separate species and of virus. And this HHV6 is a hyperendemic viral infection. Virtually everybody is infected by the time they reach the age of 3. And it's most commonly globally is the HHV6B virus. A seems to have limited geographical distribution. Like any herpes virus, it has the same pattern of infection as with herpes viruses. So primary infection, viruses shed in saliva, and then close contacts can be infected by exposure. And the only definite clinical syndrome that HHV6 causes is roseola infantile. The primary infection is in babies, and that condition is associated with febrile seizures at the time. It's usually at this very high fever, which there's several breaks, and then the rash comes on, and febrile seizures are characteristic. And all herpes viruses that establishes latency and can reactivates quite frequently, like sort of some megalovirus, viruses shed in saliva, and then its disease association is actually quite nebulous. People have struggled to try and pin it down as a specific cause of any serious condition, and it hasn't been very conclusively shown to cause anything. It's been thought to cause a limbic encephalitis in stem cell transplants, and it's also been indicated as a cause of a cofactor in systemic drug reactions. And plays a role in transplant patients, but it's not. It's nothing like this pathogens.
Cytometers.
Sorry, do we know?
Do we know the cytometers?
We know that it is latent in salivary glands, it's shared in saliva. It's certainly present in lymphocytes, but exactly, I think it's probably not unlike cytomegalovirus, although it's not shared in breast milk, which is quite interesting.
It's a lymphocytic line rather than
Yes.
saliva.
It seems to be. The lymphocytes have anti-lymphocytes into the vein. So that's certainly in culture, and those cells, yeah. So most herpesviruses, when they establish latency, the genome is present as a circular episome in the nucleus of the cell. But HHV6 is different. It actually integrates into, and that it does that even in horizontal infections in somatic cells. It will integrate if it when it gains entry into the cell that it establishes. Even and always actually integrates. And the reason for this is because so on either side of the coding region of the virus, there are these TTA, triple G, multiple motifs, so they're repeating motifs. And those are the same motifs as make up the telomere. So you have these multiple repeating, usually like thousands of those repeats at the end of the chromosome. So that is a mechanism to prevent the cell from chipping away at the chromosomes the cell. Yeah, exactly. So because these are identical to those telomere sequences, it means that the virus can very easily integrate into the telomeres of the cell that is infected. And so obviously most of us that are horizontally infected, we will have this in those cells that where HHV6 is latent. But very occasionally, it's been known to actually integrate into germ cells. And when that happens, you effectively have a copy of HHV6 genome in the telomeres of one of your chromosomes, whichever of the chromosomes, and it can integrate into any, because all chromosomes have the same telomeres. And in that context, it's basically inherited or passed down through the generations like a Mendelian dominant trait. It is, and that these, so it would seem, and about 1% of people actually have integrated HHV6 in all the cells in their body. And so it seems to be benign as far as we can tell, but obviously it can cause confusion in a diagnostic sense if because of these high levels of the herpesvirus potentially worrisome. I just thought that it's quite tricky to see that this is the sufficient analysis. Okay, so you can see that they're given examples of two different patients where so you get the chromosomes, or get a cell in mitosis, so you get the chromosomes, and you then probe them with whatever you're looking for. So here they've got the green probe is HHV6, and then the red probe is just identifying a particular chromosome that in that particular individual HHV6 has integrated into. So there it's integrated into chromosome 22, and you can see the other chromosome 22 is perfectly fine with no HHV6 in it. And then this one is integrated into the X chromosome of that particular patient.
So why doesn't this happen more often?
I don't know.
As you say, it's a ubiquitous
I
virus.
suppose it's not so easy to get to the germ cells. I don't know. I'm not sure why it doesn't happen that often. I guess you see that particular, the virus will get into that particular one, and that particular one's going to be the lucky one that ends up producing it was. So, yeah, I don't know the answer to that. But it's okay. So when would one suspect such a event? Well, it's basically what we've already alluded to, where you in the persistent detection of high-ish viral loads of HHV6 in an unexpected clinical context, or either in blood or in CSF or some other body fluid where there might be cells. And then how you diagnose is basically what we did do on this patient, they did do on this patient, do test whole blood, other tissues, and then you can do fish analysis. That is an expensive thing. I'm not going to the probe. So usually one yeah. And yeah, I think that's what I need to say. Right. And then yeah, so in terms of because of the sort of the seemingly undesirableness of the condition, there've been a lot of studies that large large prevalence studies that are done to determine the frequency of this phenomenon, and also are there any disease associations that can be found. And so the first of these studies was, or at least an early study, was this one published in PNAS in 2015. It was a study done in Canada, in Quebec, in Canada, where they have databases of patient information where they know the medical records, they know the all the aspect of things all about the patient, as well as having stored biological material. And the study, they tested 20,000 individuals between the ages of 40 and 70 to firstly to determine the prevalence of this trait, and then they looked at cases and controls to see whether to test them for various medical conditions, to evaluate whether there was any association between carriage of the trait versus with any particular condition. So we just see, so in this particular cohort, they out of their 20,000, they picked up 113 people that did have ICI HHV6, so that was a 0.58%, and prevalence, and it was about 40-60 A versus B, so 40% were A and 60% were B, and then in terms of looking at their analysis, looking at the medical conditions, the only medical condition for which there appeared to be an increased odds of a disease, where ICI people had a higher prevalence, was angina. And because as a PNAS, they wanted to take that further to try to identify the biological mechanism that might underline that finding. And they postulated that because you've got something sitting now in the telomeres of one of your chromosomes, that might result in more rapid shortening of the telomeres. And so that's what this so yeah, so they did find in this that it did look like people who had angina that were in HHV6 ICI positive did have shorter telomeres than the controls. So they there. And then this is another large prevalence study, this time done in the UK. And in this particular one, they combined two different databases, GS and then this Scottish family study, household study or something. And what was interesting here was so out of their 23,000, they're substantially higher percentage of people, almost 2.7% of their cohort were ICI positive. And the interesting thing was that it was that there was a regional difference with a high prevalence in the north here, it's not much higher than in other parts of in the south. And the difference here, so these were the two different, they separated them by the different surveys. But this survey, they classified people according to their ancestry, as opposed to their place of residence, whereas this one is their place of residence. So I think that might be why it was clearly it is more evidence in potential exposure. And the other thing they did was they confirmed that association with angina. And what they also showed, because they actually characterized the positive cases, they did genomic analysis and showed that of their 600 odd positives, more than 90% of them arose from there were only 9 lineages that accounted for those most of the cases.
Sorry, how do you interpret that association?
Which association?
The angina.
No, I don't know. Well, I mean, I think that the one the study, the previous study did suggest that there was some sort of that I mean, when the telomeres get shorter, the cell that usually, I mean, that's usually cells become senescent and they don't divide so well, and there might have been some level of also repair or inflammation or something associated with that. I mean, they didn't go into quite a lot of potential speculation in the paper, but I don't know exactly what's but yeah, so then so it's clear that there are these distinct lineages of this particular integration in human populations, and that the different lineages can really be identified by sequencing of them, and one can so there will be on particular chromosomes, whether it's the A or B virus, and then the sequence will be integration inside the chromosomal site of integration exactly, and so in this study they actually took all the HHV6 whole genome sequences from GenBank, the ICI ones as well as horizontally transmitted viruses, and lined them up to look at how they lined up by phylogeny. And so what this is looking at the HHV6A viruses, and what one can see here. So that this one is a less prevalent, less common as a cause for integration. But what you can see is, so the blue reflect currently circulating virus, so horizontally transmitted virus, and the green are all from people who have ICI virus. And with respect to A, it's quite clear that there's a distinct separation between the clades, that these have got there's a long genetic difference between this, which indicates that the integration event occurred a long time ago. In fact, they postulated between 31 um, 31 to 124,000 years ago, which is before the migration out of Africa. So it's thought that people have carried their virus with them in their lineages of virus with them. And yeah, so that is the A virus. And then looking at the B virus, it's B virus is much more prevalent. And while there's much more mixing. So the horizontal virus, or horizontally transmitted virus, and the ICI virus is more closely related, which indicates that these integration events happened more recently. Although still resumed, they estimated to 3,500. Yeah, that's what that. So in terms of what's going, virus in the host, how does it, what sort of replication or control is there in the host individuals? So we know there's 70 million people that carry the virus, and that you said those things. What does seem to be is that individuals who do have the ICI virus, they get super infected with horizontal virus very early on in life, as we all do, and that we know that the virus, the ICI virus, can reactivate, and you can actually get a replication that occur, because you can find the viral transcripts of various tissues that are derived from the ICI virus as opposed to the horizontal virus. And women who have ICI virus and become pregnant, that virus can reactivate in the placenta, and actually that it can be vertically transmitted to the baby. And then so that is it's vertical transmission. But I mean, obviously there's maybe sort of chance of actually having ICI itself, but the virus itself can also be transmitted. Yeah.
It causes congenital infection.
So no, it doesn't seem to cause any kind of clinical consequences. Yeah.
Interesting that it's more famous cousin yes.
It is very interesting that because in some bodies a very pale imitation, but luckily it's not very so just to end off with was this playing any kind of role in this patient? Was it totally a sideshow? And my feeling is that it was totally a sideshow, and that this lady clearly, as we were saying in the beginning, has some kind of immunodeficiency syndrome, and that I think the enterovirus that was detected right from the word go was probably a far more likely cause of the pathology. It fitted with with her clinical presentation, and is most likely to have been the cause. And just one other thing to say, that enteroviruses, we think of viruses that you really need T cell immune responses to from viruses, but that isn't universally the case. Some viruses are antibodies play a very critical role in controlling and clearing the virus. We talked about parvo last week. Enteroviruses are also, I got this from a review article where they showed that anyone, be it congenital or acquired immunodeficiency states, can have recurrent enterovirus infections, and is much more the antibody responses, the T cell immune responses in controlling, and that's it.